Today we're going to talk about family, friends, and foes, navigating complex relationships following acquired brain injury, and we're going to do that through looking at a couple of case examples. These are our objectives for today. I submitted these objectives, I think, back in December. And since then, a lot of life has happened. And I've had the luxury of time and being able to look at these as I've sort of developed my presentation. So I would say that these objectives actually more closely aligned or better distill down what we're going to talk about today. So we're going to talk about, the presentation is kind of broken up into two pieces. The first piece is we're going to look at how do you conceptualize a problem, or what are all the components that need to go into fully understanding what problem is coming to the surface in relationships, and including what assessments we need to be thinking about, what systems we need to be thinking about, and then we'll take that idea and we'll apply it to three separate case examples. One is a social media online presence, one is a romantic sexual partner, and one is a person served reaction to her stroke and the family's reaction to stroke. What I will say is that we use CARF language here. So instead of saying patient, I say person served. Just know that that's what that language means. I will say that all of the cases have been de-identified, or multiple cases have been combined into one perfect case in order to exemplify what I'm talking about. If you have questions, I'm going to stop after each case examples, and that way we can problem solve, or we can talk a little bit more. So I'll leave a couple minutes at the end of each case example, but then definitely more time at the end if there are additional questions or concerns. Okay, step one, our case conceptualization. We got to know some stuff about the problem, about relationships before we get into solving the problem. And so whenever someone on the team comes to me with a complex person served or a complex family systems that they're working within, these are sort of the things that I need to know about in order to sort of help anybody with a complex problem. You need to know basic demographics, name, age, date of birth, if I need to look up their chart, things such as school history or employment history. This tells me really important things. So if someone was held back in school, or didn't like school, or was truant a lot in school, we can then figure out, okay, were they truant because they didn't like school and didn't get it, or were they truant due to behavioral problems? That tells me something about that person and who they were and what they can bring to the table, even after their injury. And things like employment history are also really important. It would be a huge disservice to the person served if I assumed that they were verbal in nature, right? That they learn a lot from sitting down and talking with someone, when in fact they might be more hands-on. And so they actually have to live out the problem or experiment with the problem, or learn by doing. That information can be gleaned from some of this demographic information, which can then help us determine, okay, what's the best way to approach relationships or approach fixing relationships. We need to know something about their injury. We need to know where their injury is. That can tell us something. If someone has a frontal lobe injury, I'm going to go about things a little bit more different than I am an occipital lobe injury. We need to know time since injury. Are we still in the acute phase of rehabilitation? If so, we're going to expect a lot amount of change versus, in the post-acute phase, amount of rehab and what rehab they've done, what if they have any neurobehavioral challenges, and what interventions have worked and what haven't worked. Here at On With Life, we tend to shy away from the term of goals. It's very clinical in nature. So when we talk to a person, we always want to talk about what they want to be, where they want to be living, who they want to be loving, and what do they want to be doing, because this is a way that we can glean their values. If someone is having difficulties in relationship, it could be because there's a value incongruency there, whereas their family values one thing, they value as a different thing, or their values change following post-injury. And that value life incongruency can be a huge source of stress. And so by looking at living, loving, and doing, we can kind of informally assess a person's values, and again, then further assess how to best approach a complex relationship or problems in relationships. And then we always need to know what resources are in place versus what resources are available, which has proven to be quite challenging in COVID and post-COVID. And we'll get to that. Okay. So case conceptualization, the assessments, these are really important too. A medical examination is important because it can help us determine any physical concerns that need to be a play in decision-making, limitations and considerations. So a good example is if someone is having difficulties in their relationships and they want to go out and meet people, but they have routine or scheduled medications. Can we play with that time of medication administration? If someone has continence issues or a bowel and bladder program, can we play with those times a little bit to help accommodate things that they want to do that's more in congruence with their values? A psychological evaluation is really important, which can look at depression and anxiety, their current mood status, as well as their history, including substance use and abuse. And those might be important considerations too, right? If someone wants to go back to certain friends, but they were friends that they used drugs with, then we kind of have to problem solve around that. Personality changes and characteristics, and coping mechanisms. How a person coped before might not be a useful tool now. So how can we look at what available emotional coping mechanisms might a person have in order to bring to the table to help with complex relationships? I always pull in PT, OT, and speech because I think that they are some of the ones that have the most functional recommendations for a person served, including, functional abilities, what they can do in everyday life, but then also what are they able to carry over from session? When you're working with someone, telling them one thing and then them being able to carry that out in everyday life is a completely different story. And so seeing what actually they can carry over and carry out independently is so important when it comes to the aspect of generating solutions or implementing solutions. And then, because I'm a neuropsychologist, I think that this is super important, the neuropsychological and cognitive evaluation, which ultimately helps us determine is the person able to understand. And I actually just presented on this at the On With Life conference, and I presented a whole thing on it, and I've distilled it down into one slide, so bear with me as I kind of go through this a little bit more quickly. But all of these things are important in complex decision making. And the reason we're talking about complex decision making because in relationships, respect and consent are two extremely important things that we have to consider. And these are all of the cognitive areas that we have to consider if someone can consent to a relationship or is capable of making their own decisions, either within a relationship or otherwise. So for example, attention, processing speed, orientation, language, and visual spatial skills. These are all the foundational skills that you need in order to lay down memories and pull memories up later. So if someone can't understand the language that I'm using, I can't adequately assess consent, which then could also contribute to complex relationships and then even just communication within relationships. So you need to kind of understand where the person is at in all these cognitive domains. Like I mentioned, you need to be able to pay attention to your surroundings in order to learn new things. And then you have to be able to lay those things down in a memory. And then you have to be able to pull those out from memory, called retrieval. And you can have an independent retrieval, meaning pulling that information out from memory stores by yourself, or cued recall, which is I give you a hint or a cue that gives your brain the searching strategy in order to find that memory. And knowing how a person served does on both of these things is really important, because if you're teaching them about consent or respect and they have difficulty with the independent retrieval, what you teach them, they might not be able to apply to their everyday life because they can't independently pull that information out. They might benefit from cues, such as checklists or recognition hints or support. So being with somebody to help them provide that cue. And all of that goes into that decision-making and executive functioning component, the higher order cognitive stuff, reasoning, planning, prioritizing. Executive functioning is huge, and we could do a whole presentation on that as well. But you need all of these cognitive domains to then be used within the context of this sort of framework in assessing someone's ability to consent or is capable of making their own decisions. And I get this from Grisso and Applebaum, that's talking about consenting in medical research, but that has been routinely applied to just a person being capable of making decisions. Someone has to express an understanding of their current situation and the implication and appreciation of what's happening around them, or the severity of the situation or the implications and severity of their decisions. They have to express a reasoning through it, why they have expressed a choice or what choice they have, and why they picked one versus not another, etc. And then they also have to show consistency, meaning they're picking the same decision time and time and again. Now, someone can have a memory impairment, but because their reasoning is good and because their language skills are good, they might actually do well within this framework. So that's why you need to have both. Just because you have memory deficits doesn't mean that you are incapable of making your own decision. That's why you need to have this sort of holistic approach and holistic assessment of the person, and understanding how their cognitive aspects are working together, and then all the things superimposed in that. How does their mood status relate to all that stuff as well? Okay. Part 2 and 3 of sort of the overall approach to complex relationships. We have to identify the problem, and then we have to kind of come up with a bunch of different solutions. You can't just have one plan, you've got to have multiple plans, especially because within the context of relationships, it's more than just the one person that you're working with. It's more than just the person served that you're working with. You're also working within a context of a relationship. So other people have to be on board. So, in order to get a plan that everyone's involved with, you have to kind of come up with a lot of different solutions. Okay, this is where we get to our first case, Matthew. Okay, so Matthew is a 36-year-old male. He has an intellectual disability and has received special education services throughout his life. He was mainstreamed in school until middle school, which then he received pull-out services and extensive accommodations for all areas of academic functioning, and he consistently tested below the 5th percentile, meaning he performed as well as or better than only 5% of his age match peers. And so he meets diagnostic criteria for intellectual disability. And looking at functional abilities, such as like activities of daily living, he was significantly below age expectations. He currently lives with his mother, who provides basic cares, including continence cares. He cannot be left alone. And he came to me to see if he could be placed in a group home. A little bit of information about his injury. His injury happened when he was in preschool. He had an event where he had significant and diffuse brain damage. He had an occipital lobe hemorrhage, and then a shunt as a result. He also has a Cari malformation, which for those, it's where your cerebellum actually is herniated down into your spinal cord, and so you can get a lot of movement disorders as a result of that. But newer research is also showing that Cari malformation, depending on the severity of it, can actually have severe cognitive issues as well, including attentional related stuff. He has uncontrollable seizures, for which he has a VNS, and he also has a neurogenic bowel and bladder. He is in a wheelchair and dependent on most others for tasks. He can transfer by himself, but he needs help for other basic things, such as fine motor control, such as like eating and cutting his food. And he does really well in rehab. He does best when things are externally structured. And he is extremely interested in making friends. He feels very socially isolated. He doesn't have any age matched peers relationships. And in fact, the only interactions he has with similarly aged peers are always in a caretaking capacity. He does attend a day program, 1 or 2 days a week. And he loves going. And he enjoys simple card games and board games. But he just loves that social aspects of things. So one of the things that he really struggled with is understanding online relationships. And so he had a smartphone and he had Facebook. And when he was on Facebook, he would message women incessantly, just would send, here you can see here, he had over 180 unreciprocated messages to one woman. And these tended to be friends that he had online, or he would find women that would live in the same apartment building. These would be social media influencers. He bought a promise ring for a woman that lived in a different city that he never met. And then after he would friend women in the building, he would wait by the elevator to go and talk with them, to the point where women actually submitted their concerns not only to the apartment complex, but then also called the police and threatened legal action. So when we kind of dug down into the problem a little bit, he could explain the difference between appropriate and inappropriate behaviors. However, he couldn't always put that into practice. He couldn't really pick up on social cues. Like I said, most of his same age peers have been within a caretaking capacity, and his behavior was very difficult to monitor, because I think on some level he knew what he was doing was wrong, because he would send these 180 unreciprocated messages, but then he would go back and delete some. So it looks like, not as many messages, he didn't send as many messages. And any other sort of external support didn't work. So like checklists, or make sure you do X, or if they haven't responded, then don't send, like those external supports and reminders and checklists just didn't work for him. He had to have very direct supervision when on social media. So if we take a step back, we can see that all of his behaviors are driven by this connection seeking. He wants so desperately to have friends his same age. And it just like the day program is just not enough for him. Due to the nature of his injury, because it happened when he was so young, he actually never developed into mature adult relationships. And so we have to understand that any solution that we provide has to be at his developmental level of emotional understanding, which was quite young. Any sort of functional measure that I gave him, he consistently performed like in an elementary age sort of level. So, we would have to look at things developed for kids in order to promote understanding in him. Other interesting thing that we have to think about is, especially my generation and younger, we grew up in a era of social media and parasocial relationships at a level that maybe older generations haven't. And so with that social media and parasocial relationships comes a culture, and it comes a culture of, you don't just randomly text message Lizzo, right? Like you don't randomly just do that. And there comes a culture of like, okay, so you wait so many days to see if they respond before you send messages back. And a lot of that culture is inherent and not spoken about. It's just something that we learn because we're using social media regularly. And so teaching that to somebody, especially somebody that has some cognitive challenges, is really, really challenging, because it's teaching someone a culture, teaching someone some nonverbal communication styles, that it's just really difficult to manage, because it's not just an if-then sort of thing. I did his neuropsychological evaluation, and it's very clear that he demonstrated a lack in that understanding and appreciation aspect of being able to provide consent. So, that executive functioning, that reasoning, and appreciation, he didn't fully understand how much he was scaring women with these numerous text messages and waiting for them. He was just so eager to connect with people that he really couldn't take another person's perspective and understand how severe this situation was, now that the police were involved. What I think is really interesting is that he tested in the average range on tests of attention, but everything else, intellectual ability, academic abilities, learning and memory, were all in the extremely low or impaired range, which is really, really challenging, because it can look like they're following along with you in conversation. But then once you actually go to sort of test what they've learned or what you've talked about, they can't pull that information up. They do a really good job of parroting back highly scripted phrases, but what understanding what those means and implementing them in their own behavior is a completely different story. So what do we do with this? And this is really challenging because you know, Matthew is kind of the perpetrator in this example. If we're thinking about online cyberbullying, he is a perpetrator, but he doesn't know it. So because all of his behaviors are driven by seeking connection, that's what we're going to take and to generate solutions for this. So we're going to see if we can increase his participation in day programs. Living in a group home might actually really be good for him because it gets him connecting with other age matched peers. It also kind of simulates that launching developmental period that he didn't actually ever get. He never left his parents' house, but by going into a group home, we can sort of simulate that developmental stage. And then we had to take away his smartphone. He just can't have a smartphone. And when he uses social media on a laptop or computer, he has to be directly supervised for somebody else. And I wish that we had a better solution for that, but just because of the sort of clandestine and hiding behaviors, we just really didn't feel comfortable doing anything else besides taking it away and only under strict supervision for that. So what are some resources for using appropriate online behavior? I would say this was so frustrating for me to try and find for this presentation, because all of the resources that I found out there were about how to protect somebody from an online bully or how to protect someone from online scammers or groomers. And there was not a lot of resources out there for what do you do if the person that you're working with is actually the one perpetrating that behavior. There's not a lot of stuff out there, and I really wish that I had better information for you. But I think the thing that's most important is that the perspective taking piece was so important. And then it all becomes external structure. Those third-party apps to help control access, putting passwords on apps, including in-app purchases. This is one thing that I actually use a lot, the healthy monitoring, which is limiting amount of time on certain apps. So for me, I have an hour timer on my Instagram, and after I've been on Instagram for an hour, I can't access it for the rest of the day, which could be helpful in sort of limiting behaviors. And if we think about those 180 unrequited or unanswered text messages, that might have been mitigated a little bit had we had a timer on it. And then I actually found this online safety for people with intellectual disability, and it's a really good report. I think it's out of Australia, and it's what people have done. It's a qualitative study, and the report is the amalgamation of all the answers of what people have done to help keep their loved one with an intellectual disability safe online. And I think that's a really good practical thing to go look at. And then the last one is respect and consent. And this one's out of Canada. And it actually gives certain vignettes of, okay, so-and-so did this online. How are they showing respect? How are they not showing respect? And did they consent to this? And I think this one's really helpful because it also comes with a parent one, and it kind of gives you the answers. And looking at it, it gave answers that I didn't even think about. So I think this one's a really good one to sort of use a practical vignette in terms of teaching someone about appropriate online relationships. And then there's actually a lot of information on online dating apps about how to spot a catfish, which I thought was really interesting. If someone develops extremely strong feelings for you in a short amount of time, or if they've never met you, that could be a sign of a catfish. Watch for spelling and grammatical errors, which could indicate maybe English isn't their first language. I have mixed emotions about that one, but it's a good start. Their social media isn't so social, meaning that they are following a lot of people, but they don't have a lot of followers. All of their posts seem highly curated, just pictures of themselves, not out doing a lot of things. They're not tagged in other people's photos. Those could be an indicator of a catfish. They might not agree to you to chat on the phone or chat via video, or they may tell you they've experienced a horrible tragedy and need help. I'm thinking of the Tinder Swindler Netflix or documentary that's currently on Netflix, which is very, very good. And then how to spot some scammers. One thing that I think is really helpful is if anyone sends you and it looks fishy, if you hover over the link, it tells you where it really goes. And so people can change the link to sort of say whatever they want, but if you hover over it, it'll tell you where it's taking you. And be wary of domains that you don't recognize. Hotmail is a big one. If it doesn't take you to a mainstream site, I would be wary of it. Okay, tips or tricks. Ask to talk to them, ask questions, never give out personal information, never give out money, join reputable websites. I recommend this website, How to Spot a Catfish. Yeah, and then privacy settings. You can make your profile searchable or not searchable, which can be helpful in sort of navigating safe relationships online. That's the end of the first case example. I'm going to pause here for a couple minutes and see if there's any questions that pop up. Do I have the chat?
Not seeing any yet.
Okay. Cool. All right, well then I'm going to go on to the next case example, which is Cari. And Cari, I saw her on inpatient while she was here at On With Life. She was a 44-year-old woman. She has a history of hypertension, asthma. She has a lazy eye, depression, a history of ADHD. And while she was here, she was also diagnosed with a clotting disorder. She worked as a CNA, which becomes important later. She was independent in the home, had 2 children and 1 grandchild. And she has been with her husband for, oh gosh, 15 years, I want to say. And she claims only 11 of them are good. And their relationship was quite strained. And she told me that he was her soon-to-be ex-husband. And her injury, she was at work. She fell about 12 feet due to an unmarked hole within the concrete. And she wasn't found until 3 a.m. during the next shift change. So she had an unwitnessed fall and she was not found for maybe 8 hours, I would estimate. She had a subdural hematoma and a subarachnoid hemorrhage and occipital bone fracture, meaning, and then further MRI evidence showed a right frontal lobe injury extending back into the right temporal lobe. And she had some weird visual stuff as a result, per her OT notes. I don't fully understand it, but OT is, some weird convergence insufficiencies and some difficulties with her eyes and her vision. She also had muffled hearing. She came to rehab and she progressed really quickly, progressed to independence. I did her neuropsychological evaluation while she was here, which revealed some difficulties in attention and executive functioning, and pretty much all aspects of executive functioning, including planning, problem solving, self-monitoring, cognitive organization, meaning how well you organize your thoughts, inhibition, and then she also had a lot of intrusive errors, meaning that she was prone to making mistakes because she wasn't able to have a really good source memory of, yes, I remember hearing this, or no, I don't remember hearing this. So she tended to over-endorse things as things she's heard before, which wasn't the case. She wants to return to drive, return to independent living, and return to work. I'm gonna move this, sorry. Okay. So conceptualizing the problem. She was here at On With Life in March 2020. I don't know if anyone remembers March 2020, but that was when COVID started, which adds this layer of complexity on top of everything that we went through with Miss Cari. So I was going through my emails in preparation for this, and March 16th is sort of the day where things locked down hardcore here at On With Life. So I kind of have like a pre-March 16th and a post-March 16th. Pre-March 16th, she was seen in common areas snuggling with another person served. And that wasn't a problem. We kind of have this idea here at On With Life where a person lives here, and if they want to cuddle or snuggle, as long as they have consent from the other person and the other person can give consent, they can do that here. However, that behavior then became a problem after March 16th. And so now we have this complex message of things were okay before and now they're not okay. Cari said she didn't want, they were just cuddling. She didn't want it to progress to a more sexual relationship. However, staff um, saw more intimate behaviors such as kissing and sexual touching while they were here. So she was voicing one thing, but her behaviors were showing something different. The thing that made this more challenging, like I said, we have this complex message of before March 16th and after March 16th. And then also Cari saw herself as a natural caregiver. She really wanted to advocate for all of the other persons served on the unit here at Alma Life. And she felt that by snuggling this other person served, she was actually providing comfort and advocating for them. She didn't fully understand that he was being flirtatious with her. And I think that could be in part due to this right frontal lobe injury. Our right lobe is responsible for insight and awareness. And because she struggled with catching her mistakes and not seeing the discrepancy between her words and her actions, I think that this awareness and insight piece was a lot more impaired than what we thought. And so we kind of have to think about that as a challenge, that she doesn't have the insight that maybe we thought she did. And they all, both Cari and the person served that she was snuggling with, both had this flavor of like wanting to buck the system, which I totally get. Like, especially in March 2020, no one had any idea like what we were getting into or what was going on. And so not fully understanding the situations, like why would I have to comply with this social distancing stuff? So that makes sense. But it was something that we had to address and had to sort of confront. So again, all of these behaviors were driven by this connection seeking behavior. She, like I said, she was unaware that the person served was being flirtatious. She really wanted to advocate for this person served. Per the neuropsych eval that I did, I really felt like she could make her own decisions, even though some of her insight wasn't great. She came to the same decisions and they were good decisions each time. The other thing is that contributes to this problem is that both Cari and the other person served were lacking intimacy and closeness. Cari in her relationship, the other person served in his own relationships. And then you add COVID on top of things, when especially in March 2020, during the lockdown, all of a sudden there were no visitors allowed. And so we've taken away a huge social outlet and a huge connection component of things. How, it's and being in a brain injury rehabilitation facility, it's very scary. The other component that we had that helped drive the problem was the staff response towards sexual activity and this judgment of bad or perceived bad behavior. So again, pre-March 16th, we had to deal with like the staff response of like, but she's married. How can she be snuggling and kissing this person even though she's married? That's not really, we had to provide a lot of staff education about like, Cari can make her own decisions. This other person served can make his own decisions. That's not really our place to judge them. We can provide a lot of education about how this might not work out well, or why this might not be the best idea, but ultimately they can make their own decision, even if it's a bad decision. After March 16th, we had to have a lot of education with the staff about, you can see over here, about social distancing and how we really had to promote social distancing with Cari and this other person, and how to respond to that. And like I mentioned, we had to balance dignity versus risk. And even though that there had been intimate touch and kissing, this wasn't deemed to be a risky behavior before March 16th. After March 16th, the risk increased, or the risk changed, and we had to educate both Cari and person served and the staff about that. So what did we do? Excuse me. We provided reminders of social distancing in a respectful manner. It's March 16th. March was a scary, scary time. And we had a lot of staff, yelling down the hallway to maintain social distancing, which is not really a very dignified way to provide that reminder. So we had to have a lot of education about this is how you gently remind people of social distancing, even, injecting some humor into that. We had to offer alternative solutions, especially for Cari. We had to offer alternative solutions to provide comfort for her, to provide other persons served, and how she can advocate that for them with her voice, not necessarily her hands. And then ultimately for staff, we had to have the conversation about picking your battles. Is it important if at the time we didn't have any COVID in the building? So if they are sitting on the same side of the couch, is that the worst thing? We're not going to pick that battle. Once we had COVID in the building, it was a very different story. So we had to provide scripts for the CNAs for that. Now, this return to sexual functioning following acquired brain injury, I could provide I have done a whole talk on that. But if you want more resources on this, I highly recommend going to the model systems page. There's a really good fact sheet there. And then also the Brain Injury Association, the national chapter, has a really good PDF or like sort of manual on return to sexual functioning following brain injury, which can also include things like positioning or, use satin sheets to help with mobility. So those really sort of like practical things. I think where people tend to kind of come up against the most is, can they consent to a relationship, and that balancing dignity versus risk. And even if they're making a bad decision, can they still make their own decision? And then just monitoring our own response to that. That can be really, really tricky when it comes to sexuality and intimate relationships. Question, that was the end of that case. Is there any questions that pop up with that?
Not seeing any in the chat, but I know that balance of dignity versus risk is something that we often talk about a lot here as neuro resource facilitators, whether it's to family or group home staff. So I was wondering if you could speak more on that.
And I think that's where the importance of that multidisciplinary approach comes into play, is that you need a lot of data points in order to comfortably say, yes, this person can make their own decisions, even if they're making a bad decision. And so I understand the need to make like a lot of assessments in order to provide some sort of comfort in that. And I think ultimately, like I said, you have to go in with a bunch of different solutions, and plan A might be the optimal of, this is the decision we want you to make. But if they're going to continue to make that bad decision, then plan B through M or whatever is, okay, so how do we help you when we see this going wrong? And it can be really challenging to sort of, but if you think about it, people make bad decisions all the time. And I'm not trying to like minimize anything, but it can feel really challenging when someone makes a decision that we don't want them to make or can see it going wrong, even though they have had a brain injury. I don't know if that helps, Allison. I don't know if there's anything else specific you want me to address.
No, that's great. Thank you.
Mm-hmm. Okay, our last case is Miss Wendy. And I actually saw her as an outpatient psychotherapy person served. So I have a little bit of a different perspective with her and her family. She's a 63-year-old woman. She has a history of hypertension, hyperlipidemia, insulin resistance. Before this, she was independent in the home. She actually has 2 children, and she just had her first grandchild a couple weeks ago. Before her injury, she had a strained relationship with her husband. And we're doing a lot of grief and loss work around the death of her mother. Her mom died when she was 20 years old. And so we talk a lot about how she doesn't have a model for adult relationships, and specifically adult like mother-child relationships. And she had a left hemisphere stroke, and as a result has right-sided hemiplegia. She had a cerebral aneurysm rupture. She surprisingly does not have a lot of cognitive deficits. I think it's a little bit more deeper, maybe in the like the basal ganglia area rather than sort of that frontal and like language sort of convexity area. She does struggle with completing basic and instrumental tasks independently, and it's largely due to her level of physical dependence. She came to see me because she wanted to improve her relationship with her family, specifically her husband, and she wanted to improve her feelings of depression. What I will say is that she did go see her medical provider. She's been really resistant to any sort of psychotropic medications. But after starting working with me, we got her on an antidepressant, which has helped things. I always say that you need both. You need the psychotropic medications, but then you also need the behavioral interventions. You will get better with medications, but medications help you drive the car. They give you the gas that you need to drive the car. But if you don't know how to, turn the steering wheel, or if you don't know how to use the blinker, you're not going to be able to drive that car safely. So you need both, which really, really helped Miss Wendy. I did a lot of consultation with her PTOT speech, and she has a lot of learned helplessness as a result of her stroke. She felt her stroke was quite catastrophic, and as a result hasn't tried a lot of the things that she used to love to do, and instead would just kind of sit in one area and sort of like bark around her family members, letting her family members do a lot of things for her as opposed to her trying or learning new ways. And she had a lot of emotional ability until we got that antidepressant on board. Wendy describes her husband as unresponsive, and her son who idealized his dad. So they have a strained relationship, and then her daughter lives in the East Coast. So she is quite far away and feels very emotionally distant from her. And as a result, she has a lot of feelings of isolation. The things that make this problem even more challenging is that Wendy's always described herself as the ringleader, or sort of the activities director of the family. However, following this stroke, she's finding a hard time balancing wanting to direct people around, wanting to do things for herself, and this new understanding of she can't do everything herself. And especially in the acute phases when she had a lot of that emotional ability, the family learned to respond to that emotional ability piece. And so after we started that antidepressant, that emotional ability piece isn't more, the family was still reacting like Miss Wendy would respond in an emotional way, but she was actually practicing new emotional regulation skills. And so she wasn't responding that way. And so then we were actually getting a discord between the way the family used to react to the problem and the way that Wendy is reacting to the problem now. And so we had to do a lot of rolling with resistance in, Wendy's sort of understanding and empathy with the family of how they're reacting, but then also rolling with the resistance in the discrepancies between her words and her actions, right? She really wants to be the activities and director, as you can see, in like her standing around and telling the family what to do, but she also wants them to step up. So that means that she actually has to step back. And so that rolling with resistance is about highlighting the discrepancy between what she's wanting and telling us with her words versus what she's actually doing with her actions, which has helped a lot. I think if anyone's been paying attention, you will see that this first bullet point has stayed the same through all three cases, which is all of these behaviors are driven by connection seeking, wanting to connect better with other people, which is the whole thesis of having relationships. She has a hard time giving up control. She's extremely rigid, both in terms of how she views relationships to be and how she wants to be in relationships. And the family was still in mourning and figuring out their new roles following mom's stroke. I think a perfect example of this is I recently did a co-treat with her OT. And, afterwards we had a debrief session, and her husband was talking about how he's mourning his retirement because he wanted to travel in his retirement. And she was talking about how the eggs are flavorless. And so they're just not on the same page in terms of like their vision for what is happening. He's still grieving this loss of his retirement, and she's frustrated because he wouldn't cut up a pepper for her eggs. And so getting everybody on the same page can be helpful in creating successful familial interactions while also helping other people in the family sort of adjust to their new roles and sort of grieve whatever losses that they need to grieve, because the roles have been changing. So with Miss Wendy, what we've been working with in the family is instilling perspective taking techniques, not only for Miss Wendy, but also for everyone in her family. And because she's extremely rigid, we also focused on that solution generation. So coming up with a bunch of different solutions to the same problem, because that helps with rigidity, knowing that there's more than one way to do things. And that also helps with perspective taking. And so if you come up with a lot of different solutions and so picks X, you can say, oh, I understand why that person picked X. That was an idea that I came up with too. And again, rolling with resistance, highlighting the discrepancies in our actions versus words, and again, picking your battles with Miss Wendy. And that really helps the therapist a lot. I think one of the most important facts in familial relationships is that emotional changes and personality changes are actually the biggest predictors of familial mental health, satisfaction, and divorce rates following acquired brain injury. For so many reasons, whether it's insurance or whatever, outcomes are highly, highly focused on functional, meaning physical. But this other component of personality and emotional need to be addressed. And I think I'm preaching to the choir here, but like these need to be as important in thinking about discharging and thinking about helping the family, because these personality changes in mental health, emotional changes can influence the family so much. Again, I highly suggest looking at the model systems for some basic resources on this. For when working with person served and familial relationships, it's equally important to work with the family, meaning providing the family with recommendations and interventions. So I always talk about getting your own therapist, because that is one relationship where you can be 100% about you and you don't have to worry about that reciprocity, which means you get to be selfish in therapy, which means you can actually think about yourself, think about your environment, and think about how to respond to things in a way that can promote change and promote healing. And then also getting education about the person served, about yourself, and then about the acquired brain injury. We have care partner support groups here, which can be really, really helpful in both of those things. We also have brain injury education series, which can be really, really helpful in providing both of those components. And consider attending therapy with your care partner, meaning or the person served. I think one of the things that was the most helpful was that co-treat between Wendy and her husband, and then I got to watch it and participate in that co-treat as well. And it was so illuminating just seeing how the behavioral patterns sort of play out. We can really pull apart that they just were not on the same page. And so the very first thing we have to do is get everybody on the same page. You can see here with the same info and the same goals. Okay, that was the last slide for that case example. Are there any questions about that?
Not seeing any, but thank you for providing recommendations for family members as well.
Yeah, absolutely. Just in summary, adequate assessments, getting multiple perspectives, getting multiple data points can help fully understand relationships and how the problem is presenting potentially in more than one area, or getting a multifaceted view of the problem. Two common themes that were present throughout all of the cases today is perspective taking, and sort of teaching and instilling and promoting perspective taking. And the last common theme is connection. I was in a study abroad program in college, and he said that the most important verb is to connect. And I really think that is what has driven both me and my own personal and professional goals. And then also that's what's driven all of these persons served and then has resulted in all these challenges. So thank you for your time, and I will stick around for a couple minutes if there's any other questions. Excuse me. So Roxanne asks, what is your recommendation for a guardian who does not accept their adult child is relationship connection seeking. What is your recommendation for a guardian who does not accept their adult child is relationship connection seeking? That is so tough, because I think I would start at asking the guardian about what they understand about their adult child, and if they understand that their adult child is connection seeking. A lot of times we can identify, we just by changing, like if you notice, I don't use the words attention seeking, because there's a lot of negative connotations that come with that. If we change it to connection seeking, that allows for more empathy. It sounds like that, you know, maybe they don't fully understand the utility behind their adult child's behaviors, right? So they don't fully understand that what they're doing is connection seeking. They are seeing it as attention seeking, or they're being something, right? They're being difficult or whatever. So I would start with, you know, helping the guardian understand the utility and the adult child's behaviors. And then I would go to a place of empathy and ask, you know, is there a reason why you can't provide your child empathy? Are you tired? Do you need more respite? Can we get this adult child resources another way, such as a day program? Can we get them, another care partner? Can we get them sort of in-home care? Like asking other ways. If the parent can't provide that connection, can we get that connection in other ways? Without knowing more information, that's kind of what I would start with. That was a good question, Roxanne. Thank you. What else? Anything else? I don't see anything. Feel free to reach out to me. My email address is there if you want to reach out for anything.